Okay, Ellen, we are recording.
Okay, so this is starting.
Well, we still have 2 more minutes, so let's give everyone some time.
Okay.
In the meantime, if you've just joined us, you certainly want to go to the chat box and catch up with some of the conversation. And it looks like Deborah Pascali-Bonero is talking to you.
On start video. Non, je veux qu'on me voit moi.
If you if your video is not muted, please mute it. Yeah, thank you, so that we can not have trouble getting this audio in. Thank you.
You see, Ray, that my daughter is will watch the video.
Wonderful. That's your daughter. Great. The one with the baby.
Yeah, the baby is fine. She's here for today.
Oh, that's wonderful.
We see her on video.
Hi. Sorry, I'm muting your video. Oh, Ellen, I didn't mean to mute you. Hello, Mary Sagady, Leslie. We are fortunate that we have several board members here. And so...
Can you put my video on back, Ray?
Oh, I took you off. Sorry, Ellen. Oops. It says ask to start. I think, there you go.
Okay, that's good.
So we have, for those of you who are participating as participants, when you look at the participant list, you can see Molly. I'm not very good at pronouncing your name, Molly. And then Mary Sagady Leslie, who have joined us from our board of directors. And I'm Ray Davies, the administrative director of IMBCO. I am not Deborah Pascali-Bonero. She is up there in spirit. I know she's with us. She's busy off at another very important meeting. So I now have 3:02, and it is my pleasure to introduce Alain, who is going to be, she's also on our board, and she will be introducing step 1 of the IMBCI. Alain, I'll let you start.
Thank you, Ray. Hello, everyone. I'm very happy to do that. This is the first web presentation of our 10 steps of IMBCI 10 steps. So we're starting by step 1. So I'll continue the presentation from there. I'm very happy to see that there are several people interested in that, and I hope you have a nice time. We're going to take questions at the end, but if you have a pressing need to say something, well, you can raise your hand. There's a place where you can raise your hand, and we can interrupt the presentation. So, this is all about respectful maternity care. And in the charter that was launched by White Ribbon Alliance for Safe Motherhood, one of the first thing we can read is that in every country and community worldwide, pregnancy and childbirth are momentous events in the lives of women and families. And they represent a time of intense vulnerability. And since the concept of safe motherhood was usually restricted to physical safety, but that there are other dimensions to childbearing with deep personal and cultural significance for a woman and her family, the notion of safe motherhood must be expanded beyond the prevention of morbidity and mortality to encompass respect for women's basic human rights, including respect for women's autonomy, dignity, feelings, choices, and preferences. So this charter is a landmark in the international recognition that there was a problem regarding respect and dignity during childbirth. So this presentation, I will talk about what is IMBCI, the International Mother-Baby Childbirth Initiative, and I will tell you what the step one, what it is, and what is respect and what is dignity. A bit about the evolution of the international movement about respectful maternity care and obstacles to these two concepts, respect and dignity. There will be also a part on how the first IMBCI demonstration site implemented IMBCI, and that it is feasible under any circumstances to implement IMBCI, among which step one, which is all about respect and dignity, because it's been implemented in the Philippines in 2013 in the aftermath of a typhoon by Mercy in Action, an organization staffed with midwives that train local midwives. So if they manage to implement IMBCI under these circumstances, anybody can do it. So, and we're finished by looking at how do we evaluate compliance regarding respect and dignity during childbirth. So for those of you who are less familiar with IMBCI, it's an initiative that stemmed from the meeting in 2005 of an international group attending the Coalition for Improving Maternity Services, KIMS annual conference. And KIMS launched the mother-friendly childbirth initiative. So this is the international, ours, the IMBCI, is the international version of what originally was American. And the idea came after an international survey done by the University of North Carolina revealed an overwhelming support of mother-friendly care. So this is one of the first meetings of the International Committee at KIMS convention in 2006. So you can see Deborah on the second row towards the right. And you can see some other members, Maureen, bottom left. You can see Ricardo Jones in the middle, right beside me. Anyway, we were a bunch of people who really wanted to get mother-friendly care in the whole world. So brief her story of IMBCI. It started at a meeting in Geneva in 2006, where the results of the survey were presented, and where about 15 people working for international organizations were part of it, on whose premises. After that, well, it started there. A researcher and anthropologist that probably all of you know about, Robbie Davis-Floyd, wrote during 2 years to write successive versions of IMBCI, submitting them to representatives of international organizations, to KIMS International Group. Anyway, between 100 and 200 people looked at different editions of the draft of IMBCI. And finally, in 2008, it was finalized, and IMBCO, the organization, was created, helped financially first by an American organization. And a call for demo site was launched, and the first demo sites were accepted in 2010. So this is the board of directors as it was in 2010. There's still, you see Ray in the middle, kind of left. You see Daphne Ratner, a professor and researcher in Brazil. You see Robbie Davis-Floyd towards the right, and then Deborah at the right. And in the middle, you see Rodolfo Gomez, who is an OBGYN now working for WHO in South America, who was part of the board at some point. So what is it? What is this initiative? It's created on the model of the Baby-Friendly Initiative. It's based on women's fundamental rights around childbirth, and it has basic principles like human rights, right to health care, midwifery approach to maternity care, evidence-based care, importance of continuity of care, autonomy of the childbearing woman. When we see midwifery approach, doesn't have to be midwives, but caregivers have to have a notion of what the midwifery approach is to childbearing. And it contains 10 steps based on a mother-baby model of care. Its main features are respect for childbearing women, their baby, the unit they form, their fundamental rights of women during childbirth, respect for the decisions and choices they make, the physiology of birth, and promoting evidence-based practice, promoting other aspects as well that are important, like skilled emergency treatment, collaborative care, breastfeeding. And it's been implemented since 2010 in some hospitals, birth centers, individual practices in different regions of the world. So this presentation is about step 1 of IMBCI. As you can see, it says step 1 that optimal mother-baby maternity services have written policies implemented in education and practice requiring that its health caregivers treat every woman with respect and dignity, fully informing and involving her in decision-making about care for herself and for her baby, in language that she understands, and providing her the right to informed consent and informed refusal. So we did some surveys, informal surveys, when we were giving presentations on IMBCI in conferences here and there in different regions of the world. And step 1 was always the preferred one, like the first one that came to people's mind when asked about IMBCI 10 steps. So what is respect and dignity? What is respectful maternity care? Well, you know, we can look at the dictionary to see what is respect. And in this dictionary, there's 2 definitions: to feel or show differential regard for, esteem or admire all the other, like, for instance, all the other scholars respect her. Another way, to avoid interfering with or intruding upon. Please respect my privacy, which is something that should be respected during childbirth. Or to avoid violating. I respected the speed limit. So, and dignity. Dignity has to do with the quality or state of being worthy of esteem or respect. It's another definition: inherent nobility and worth, the dignity of honest labor, which is funny because we're talking here about labor and birth. And according to the survey Dignity in Childbirth, which was done in UK in 2013, and I will refer to that survey several times in this presentation, dignity encompasses respect and autonomy. And dignity includes bodily integrity, which is something, you know, that we can more easily think about, but it also includes emotional integrity, which relates to personhood. And research has identified the following factors that contribute to dignifying care. Those are choice, control, compassion, choice by the woman, control by the woman, compassion, communication between a caregiver and the woman, kindness manifested towards her, respect. So those 2 concepts, respect and dignity, you know, there's some overlapping, sometimes one includes the other, sometimes some factors in one can be seen in others. And we can ask ourselves, you know, how come the respectful maternity care movement came about? Because it was in reaction to disrespect and abuse, which became also known as obstetrical violence. And this began sometime even since the 50s, since the birth started to be medicalized. And some women reacted to how they were treated. There were advocates in the birth movement that underlined disrespect and abuse, and some caregivers also. However, until 2010, there was no international recognition of it. And here I did a graph on the international recognition of obstetrical violence, disrespect and abuse. This presentation is about respectful maternity care, but we can't talk about it without at least mentioning the opposite, and so why it came, it needed to be recognized. So in the 50s, you see that there was an article in an American magazine called Cruelty on Maternity Wards in the Ladies' Home Journal. And then after that, there was the book by Dr. Le Boyer, a French doctor, Birth Without Violence, which had mainly to do with without violence to the baby. Anyway, it did something also for the woman, but it was not the focus. In the 90s, there was a couple there was an article by Kitzinger who compared the words women used when they were had been abused sexually and the words women use when talking about their childbirth, their birth experience, and there was a lot of similarities. So, but it's only, with an exception, since the years 2000 that it's been increasingly recognized. We're only at the beginning of that, but since it's now recognized by international organizations, it has a lot more weight. So you can see 2010 USAID wrote a report about where it was at. 2012 there was this international charter on the universal rights of childbearing women, and in 2014, WHO made a statement on the prevention and elimination of disrespect and abuse during childbirth. So this was really the first huge organization that acknowledged it. And the White Ribbon Alliance wrote, after the charter, they wrote an article on, the movement that led to respectful maternity care. So, but why, since women have been denouncing and advocates have been denouncing some of the things that were happening during childbirth, why did it took so long to become recognized? Well, at some point there's a timing, and some ideas take time to be recognized. So a few years before 2015, when some countries and some people working in the maternity health sector realized that they would not meet all the goals of the United Nations Millennium Development, in particular, it's goal 5, improve maternal health. Well, it was like, okay, we won't meet the target. What's happening? So it was realized then that in many countries, women chose not to use maternal health care in order to avoid disrespect and abuse in healthcare facilities. So that was kind of the reason or the way to get into the healthcare system and public health in order to make respectful maternity care become more, more recognized. So these are the steps I talked about when I showed the graph. So I won't see. I'll just pass that. And in 2015, which is only last year, it's very recent. In the last few years, a lot of things happened. And USAID published Maternal Health Vision, where respectful maternity care is defined as a crucial and strategic feature that can contribute to diminishing maternal mortality, disrespect, and abuse during childbirth. So the important thing in that, apart from the recognition, is that the respectful maternity care started to be included very, very recently, not more than a year ago, in the definition of quality of care. So until then, it was focusing on access to care, skilled caregivers, evidence-based care, but it did not include the woman's experience of care in the definition. So now it's included in it, and quality of care is now an alliance between the public health perspective on quality of care as we knew it for a long time, and the advocacy approach, the defense of human rights in healthcare. That's a major change, because if it's now in the definition of quality of care, it means that facilities and caregivers have to be more conscious about the importance of it. So finally, WHO, a year ago exactly, includes the dimension respect in maternity care. It published a frame of reference on quality of care in newborn and maternal health care. So it's a great moment, I think, for the women and their babies that this is happening. But there are obstacles to implementing respect and dignity. You know, although it's not, you know, it can make us understand why things sometimes don't happen, but working conditions can contribute. You know, when there's not enough personnel, it's harder to be, maybe, you know, to assure women of their presence, and it makes things more difficult. And there's also now a goal towards absolute compliance regarding guidelines and protocols, and a lack of individualized care. There's also, and it's been like that for a long time, fear of litigation, especially regarding high-risk births. And more time is now being spent to document what's happening during the birth than being with the laboring woman. And the facilities, some studies have shown that there's more respectful maternity care in birth centers than in hospitals. You know, we cannot generalize and say that all hospitals don't respect women, not at all, but it's been shown that a midwifery approach is more conducive to respectful maternity care in a birth center. And there are some factors that are related to the childbearing woman. For instance, giving birth for the first time. Women don't really know what to expect and what their rights are, or what should be, what is normal and what is medicalization. And having a high-risk pregnancy also is an obstacle, because a lot of the focus then on the baby. Having additional vulnerability factors like the ethnic origin of women, women who have a handicap, women who have, are defined as overweight, and women coming from lower, if we can call that, socioeconomic class. So it means that when there's added vulnerabilities, there's more of a chance to have disrespect and abuse, and that's been documented and studied for all sorts of populations also, not only childbearing women. So now I'm going to talk about the first IMBCI demo site, which is in Canada, in Quebec, and I happen to live about 15 minutes from that place. So it's really nice, it's been really nice for me to accompany that hospital in implementing IMBCI. And this hospital has been very well recognized in the Quebec milieu as an avant-garde facility, being the first baby-friendly hospital in Canada before anyone else, and for a long time alone. So they were open to try IMBCI. So this is a hospital in a nice city of Quebec. In the fall, you can see the trees. So what happened there? Well, there was an inspiring leader who is the chief of the perinatal sector, and she's coordinating also the pavillon de naissance, which is the place in the hospital where women give birth. And she's a really leader in the sense that she really succeeded in convincing her team that IMBCI was an excellent thing. And so what they did is they started by building common knowledge. They had doctors within the team and nurses looking at books on normal birth and evidence. And they hired also a midwife, one of the more experienced midwives in Quebec, to write a document on the physiology of labor and birth, because they identified, there were a lot of things that were quite good there. And I know because I witnessed the birth of my granddaughter there. And but what they were lacking was all the midwifery physiology approach to birth. So they decided to work on that. And they developed and gave training for all types of caregivers, healthcare professionals working in the facility, doctors included, because sometimes, you train the nurses, but the doctors, no, here it was doctors. And the training was done by doctors, midwives, and nurses. Although there's no midwives working there, there's no midwives in that hospital, but they are in birth centers, so they invited some of them. The other thing they did is to involve the personnel in identifying what was well done and what needed to be improved and what ways to achieve it. They revised totally the prenatal courses, both the content and the structure. They didn't have any need to improve the physical space because it was already, unique rooms for women in labor, and then the birth happens there, and then she stays there until she leaves the facility. So that was good. And they also started to evaluate, if the compliance towards the 10 steps. So here was taken in 2010. You can see Rodolfo Gomez in the middle, and Christiane is the second to the right, and I'm behind. And that's her team and her assistants, nurses that assist her. And so they were really enthusiastic about IMBCI. So those are examples of books that they read or videos that they showed in order to build the common knowledge. That's the document. It's not exactly it, but I had to invent one, so I took a picture of this one. And the training was done by different trainers to all categories of caregivers, as I said. A midwife, Anne Goubaillon, who is the coordinator of a midwife staffed out of hospital birthing center. She gave part of the training. The chief nurse, Christiane Charret, whom I talked about, also was involved. And here's a doctor, an OBGYN, a very interesting guy who has been and still is for years the director of the More OB SOGC program, the Society of Gynecologists and Obstetricians of Canada. But there's a chapter in Quebec, and the director is Paul Gagné, and he was part of the training team. And you see Rodolfo Gomez, who is willing to learn, and this is a hands-on approach to training. So the assistant chief nurse, Louise, at the right, is teaching him how to use that bed and how to finally, to grab the handlebar and push. So that was a funny part of our visit. They also revised prenatal classes. And this is not exactly what happened, but I chose this picture because there was a lot of women in it. And this is called the Yoni Fest. It's an event that happened a couple of years ago in Quebec, in the country, about birth, about the birth humanization and women's rights and everything. It was a very nice event. So it could have happened that way, that women talked about prenatal classes and how, what needed to be changed. There was not a lot of need to modify the physical space. I personally would change all the beds in there who are single beds, boarding beds, like technical beds can do this or that, for double bed like that, but they prefer to use the other beds. So we are talking about step one, but there are examples of other steps that facilitate respect and dignity. For instance, the midwifery approach to maternity care. Our step two is possess and routinely apply midwifery knowledge and skills that enhance and optimize the normal physiology of pregnancy, labor, birth, breastfeeding, and the postpartum period. And in our step 3, it is about information. Inform the mother of the benefits of continuous support during labor and birth, and affirm her right to receive such support. So that's part also of the definition of step 1, as you can see in the IMBCI. But you can say, well, you know, this is very good. Canada is a rich country and has lots of money. Well, it's less and less so because we are, you know, government is lowering the budgets and here and there. But we can see, we had a presentation a couple of years ago by Mercy in Action organization because they implemented IMBCI in their birthing center. And also they decided when the typhoon really hit badly the Philippines to just go in the disaster zone and help women, pregnant women, help women have a baby, help women, you know, in the first few days after having the baby. And it was all done within the framework of IMBCI. So this is the birth center that's a designated site for the International MotherBaby Childbirth Initiative. And this is the team. Vicky Penwell is at the center, and you have local midwives that have been trained. So there was an article, you know, that 12,000 babies were on the way in the typhoon-stricken region. So that's why they decided to go. So this is a tent. They set up tents in a building that had not been touched, in a school, I think, in order for women to be able to give birth, receive prenatal care and give birth there. So at the bottom, you can read that Mercy in Action is proud to say we provided all 10 steps during our disaster response after super typhoon devastated Leyte Island in the Philippines, with no electricity, no running water or indoor plumbing, with every one of our patients homeless, traumatized, coping with loss, and to some extent deprived of adequate food and clean water. So those were the conditions they were in when they went to that zone. So the first step was to build. There were also tents that were built outside. So you can see a mother who had given birth in a tent. And then you can see another woman with a local midwife who had just had a baby also. So this shows that it's not a matter of resources. It's a matter of changing the attitude, changing the knowledge, changing the culture surrounding birth. So what makes respect during childbirth possible? Well, how birth is viewed in the facility by the managers, by the caregivers who work there. So the culture is changed. And it also implies a caring attitude by the personnel, warmth, empathy, patience, an environment that facilitates dimensions of respect of the woman's privacy, of the confidentiality about the care, of individualized care. So, okay, this is very good, but you know, how do we know if step 1, for instance, if the facility complies with step 1? Well, we put an emphasis on women's experience. So we devised this questionnaire, and the facility in Quebec has adapted it in order so that women could answer it before leaving the facility in an anonymous way. They would put the thing in the box, and you know, they couldn't be related to their name personally. And it was in 3 versions: one for women who had a vaginal birth, one for women who had a cesarean during labor and birth, and one for women who had a planned cesarean. So this is a questionnaire that evaluates about 7 steps out of 10, because some others, you know, it's best if the administration answers and stuff. So, but this one, by women. There's 7 questions out of 30, so almost a quarter of the questions, 25%, who directly relate to some aspects of step 1. And there's also other questions where we can see in the question and in the answer if some aspects of respect and dignity are there too. So I'm going to show you the questions that relate directly to respect. So we had to find ways to, okay, you know, how do we do this? So one manifestation of respect is when care providers introduce themselves the first time they come in the room. You know, that's only normal. Sorry about that. It's only normal that, you know, people introduce themselves. And so pregnant women and their partner or family know who they are. The other question, during my stay in the hospital, the information I received was explained in a way that I could easily understand, because it's not only something to give information, you have to know if the woman is able, you know, it was given in a way she can understand. So those are done with a scale from never to always, or as you can see, no one did this for the first question, to yes, they all did this. A question about the privacy. I felt my privacy was protected while I was in labor or recovering in the hospital. And here you have a scale also, because sometimes it can happen sometimes, and sometimes it never happen. And about the information and the involvement of the woman with the decisions. Those 2 questions relate to the information. During my stay at the hospital, I received adequate information about everything I wanted on what was planned or happening: labor, birth, treatments, their alternatives, breastfeeding, etc. So a woman has to choose only one answer. Another question, I was informed of effective family planning methods during my pregnancy and before leaving the facility. So this is it's either yes or no. And the involvement in the decision making, which is really important. It's an essential feature of respected childbirth. My care providers included me in all decisions about my care and about the baby's care in the hospital. So we divided that by type of providers. So for nurses, for doctors, and if there are midwives on the premises also. And respect of the choice, you know, the question of informed consent and refusal, I felt my choices were respected. So it doesn't show on the slide, but on the questionnaire, you have the scale, you know, never to always, after each period, like in all the sub-questions, at the end of my pregnancy, during my labor, at the time of the birth of my baby. And another question that's more an indirect question, but it allows us to see if women can make choices, you know, important choices. Like in labor, I felt free to use comfort techniques, including, and then we put a list and some drawings in order to facilitate the recognition of what could have happened. Another, I had freedom in labor before the pushing phase to move and use different positions. The same thing, a list and drawings. And a question, I was able to move in the position I wanted before the birth of my baby. Well, maybe, you know, here we could have asked if no, why, but we didn't. So, in conclusion, things that matter. Well, respect and dignity has to do with respecting the childbearing woman and her baby. But it's not only that. It's not only a matter of being nice and considerate towards a woman and her baby. It's a big part of it. But it's also in the MBCI, the emphasis on respecting the physiology of labor. And it's also about an attitude where caregivers respect the woman's capacity to make decisions. And also they respect her capacity to give birth, you know, which is, I think, somewhat lacking in the medicalized model of care. So, dignity, the survey Dignity in Childbirth was done in UK in 2013. They not only asked women, but they interviewed midwives. So some of the things that came up were structural changes in the approach to maternity care towards continuity of carer, not only of care, but when the person is known, the caregiver is known to a certain degree by the woman, it changes things. It needs better training on dignity and personhood, in explicit dignity guarantees and dignity champions, maybe on maternity wards. Better channels for feedback from women about their experiences regarding that in childbirth. It also means to give enough time to caregivers to reflect on their practice. And also formalized emotional support for caregivers, because caregivers go through different, sometimes difficult things, difficult births, or they witness something they don't agree at all with. And I think emotional support is important. So we could summarize what is respect and dignity during childbirth by making it the 3 C's: consent, communication, and caring. Caring here means emotional support. And this is very important, that women consent or can refuse, that the communication between them and the caregiver is good, and especially the attitudes of the caregivers, and that there's a caring atmosphere. It's a very important, as you all know, period of a woman's life to give birth. So these are the references I use for this presentation. Our initiative IMBCI, the survey, the documents published by the White Ribbon Alliance for Safe Motherhood and by the World Health Organization, the presentation by Vicky Penwell on what happened in the Philippines, and where the pictures come from. So I just wanted to say that I've published, I did a thesis that had a relationship with humanizing birth. And I wrote an article in 2002 stemming from my doctoral study. And I did lots of presentation on the subjects. So thank you very much. I'm really happy to have been able to share that with you, and I will really be happy to hear about your reactions.
Thank you so much, Helen. That was full of information, and we had a couple of questions.
Okay.
Was asking or made the comment. She said, "Are these questions on the IMBCO site?" She said that there is great feedback, questions for families and care providers. So I thought you may want to address that. And also too, just to remind everyone, is this presentation will be available as an archive on YouTube, and we will send you that link when it is available. So, Ellen?
Oh, well, maybe you have more the answer to the question. Are the women's questionnaire on the website?
No, no. Just tell me when. I'll put them up there if you want me to.
Okay, well, we'll see to that they end up there shortly. Yeah, I think it's a great idea that they are available. There are other, like Dignity in Childbirth, the UK survey would be a good source also of questions. And there's also a study being done right now in the States on childbirth experiences, on women's experience in childbirth. And I've seen the questionnaire. I could send it to you if you wanted, but it's like, there are several questions also that pertain to evaluating respect and dignity during childbirth.
Wonderful. Let's see here. You're getting lots of thanks in the chat box for a great presentation and great photos. And the second emotion, Kay said, very helpful and relevant presentation. Look forward to seeing all the questions. So that should be good. And Hakan said, thank you. I think everyone can read these. Can you read these, Ellen?
Yeah, I can.
Okay.
Yeah. Yeah.
He does ask, how long did it take Quebec to decide about being one of the presentation sites or the demonstration sites? And then how long did it take to succeed the 10 steps?
Well, it took a few years before the idea, because Christiane was part of a perinatal committee I was on by the Public Health Association of Quebec, which is an NGO in Quebec, who's done a lot regarding humanization of birth. So I brought, I brought the MBCI initiative into Quebec and presented it to the group, and I translated it into French. And so Christiane thought about it, and I think in 2009, which is a few years, after, maybe 3 years after it was presented to Quebec people, she decided, okay, we'll go ahead. We want to be a demonstration site, and we want to do everything. So in 2009, they applied, and they were accepted, I think, at the end of the year or at the beginning of 2010. And then it took them 3 years to prepare themselves, because for Christiane, it was really important that it was a global effort from everybody, and that the doctors would be in, because sometimes it's not always easy. In the direction of the hospital, like the management of the hospital would be in, and so and she was used to do the certification of baby friendly, so she knew how to go about that in order for it to be implemented. And how long did it take to succeed the 10 rules? Well, they started to implement in 2013, and a lot of the steps, I would say, were already met. But, the physiological approach to birth and stuff, that really was the big step for them to achieve, because there are several steps that pertain to that. And I would say, for me right now in Quebec, this is the best place for women to have a baby, from the INBCI point of view, from the evidence base, from respect towards women, from the respect for physiology of labor and stuff. So it took a few years, but I would say not too long, and it's happening. It's really happening.
Alain, Judith from Hungary asks, are there training materials and assessment tools similar to the BFHI, the Baby Friendly Hospital Initiative, for the IMBCI?
Well, in Quebec, IMBCI, we devise some guides to help demo sites implement IMBCI. But the Quebec site, they have a whole, how do you say that? A whole file or whole book, I should say, on how to. I wanted to find it because I have it somewhere, but I didn't find it to show it to you. It's like what every person in the facility should have read, and do some homework during the training and stuff. So they devised something that would help implement IMBCI, but it's in French. So that's the answer.
Yes. Celine, who I got to see a photo of in your presentation, asks, did they have changes in issues for women and babies? I assume that question is with the women's questionnaire.
Okay, well, I'm sorry, I don't understand the question.
Celine, go ahead and restate your question if you don't mind. In the meantime, I'll go through the other ones. Vicki Penwell stated that she thinks that this series of 10 webinars will be wonderful training materials, which I think I agree with her is wonderful. And the Mercy in Action created a 40-hour training. They've not published it yet, but it was successful in the Philippines as a capacity building program after the big disaster. I would definitely welcome seeing a 40-hour training program on the 10 steps of the IMBCI, Vicki. So just let us know when you're ready to do a webinar. We'll get it going for you.
Oh, yeah. Yeah. Is Céline Lemay there?
Yes.
Okay, that was her question. Céline, by the way, was the one who wrote the document on the physiology of labor. The common knowledge document.
And Sue mentions that if a site is interested in joining in, we can put them in touch with our successful sites to see how these sites are managing to make it work.
Oh yeah, there's a site in Brazil, there's a site in Austria, and there's the Philippines. So different in different types of countries, or it's happening.
Well, the chat box is humming. So there's some really good thoughts coming from Sue Down. And Celine clarified her question, I believe.
Okay, what's Celine's question? I don't see it.
Well, it was about interventions, and if there was any, my assumption, Celine, is there less interventions because of promotion of physiology?
Yeah, well, I remember that Christiane did a presentation on MBCI on that, remember?
Yeah.
But, Christiane couldn't be here today. It would have been really nice to have her, but she couldn't attend the presentation. But I think it did lower some interventions rates. I don't know if it did it for all, but they have, for instance, one of the, they're among low rates for epidurals, and they're among very low rates for episiotomy. So I think it had an impact, although there were, relatively good rates from the beginning, but I'm sure it influenced it, but I cannot answer totally that question.
And you know what I'm going to do at the moment? I'm going to unmute all, just in case someone has something to say. I haven't seen any hands raised, but I will unmute you all, and you will have an opportunity to ask Ellen a question.
Oh, that's a good idea.
Oh, I'm still hearing some wonderful music. So I want to say once again, we've had several of our board members participate here. Sue Down, Amali, and Amali, the mic is open, so you can pronounce your name if you want.
Amali Lokugamage, it's Sri Lankan name.
Thank you, Amali. And we have Mary Segedy Leslie back on our board. Mary, thank you. We're so glad you're here.
Hi, great to be here.
Yeah, hello.
And Sue Down, you're here.
Yeah, hi, I'm here. Hello, hello. Yep.
I know you always have so much to offer when it comes to facilities and making improvements in the care they give, and such wonderful work that you've done. If you have something that you want to add, Sue, and I think that what you really ought to mention is the step that you're going to be doing and when you're going to be doing it. Because technically you were supposed to be doing step 2 next month. However, you need to switch it. So go ahead and describe what step you're going to do, and which is step 2 in August. And this is Ray Davies, not Deborah Pascali-Bonero, and I will be doing step 3 in July instead of Sue Down. So July 11th will be the next one. And then Sue, go ahead and give us a little update about what you'll be doing.
Yeah, sorry to confuse everybody by making my step 2 in the step 3 slot, but I just happened to be on holiday, so unfortunately that's why I can't do it. My step is really about physiology and midwifery largely, so I'll be talking about that, but within the context of midwifery as defined by the Lancet series on midwifery. So not just what midwives do, but this notion of the philosophy of midwifery, which should be applicable, as Helene's alluded to.
Nemzetközi anyabababarát szülészeti ellátásért kezdeményezés magyarországi referense. Amiért ezt az országjárást elindított.
I don't understand.
All right, sorry. Yes, sometimes background noise is an issue. Sue, were you able to finish?
Well, it was just, yeah, I just stopped. So I wondered if somebody was asking a question. So really, it's, I mean, there's not much more to say than that at the moment because I haven't finished writing the talk. But that's the scope of it anyway. So physiology and midwifery largely.
And Hakan's last comment here is wherever we talk about IMBCI and especially one-to-one support, the obstetrician's first fear is that they, quote, they will intervene with my work, but I am responsible, end quote. How did you convince them that this is nothing to do with them telling them what to do? That's a very good question.
Yeah, well, Christian would be in a better place than me too, but I know that it did some work to convince a couple of OBGYNs, but you know, Christian is very patient and she knows how to continue working and how to find approaches in order to overcome obstacles, and that's what happened because you know they all are in it, and maybe you know some doctors at first are more reluctant, but you know if they see the benefits also, if they see how women react and how they are happy and how the couples are happy, and you know that's an incentive to okay, you know that there's some good in that approach, and we will support it.
Well, it's been an hour and we committed to, well, almost an hour, 55 minutes. So let's just.
Well, Ray, can you talk about what you're going to talk about in regarding step 3?
Well, I'm so glad you included that in your presentation, and it was wonderful that step 1 really does lay the foundation for so many of these steps. And in particular, as a doula training, I will be covering that that type of support and information that women receive in childbirth, or receive not only in childbirth, but during labor and birth. And so much of what you said is so much of what the doula does to protect and support the woman's birth experience. And I protect her memory basically and support her in the birth experience she's looking for. So there will be a lot to discuss, and doulas fortunately have become internationally known and respected. And so I hope too that we will clear the air and make sure that everyone has a full understanding of what a doula does and does not do. Because as Hakan said, that physicians were concerned about being told what to do, they're concerned with that, with other people being in the room as well, including doulas. So that's not their role. So that will all be cleared up. Thank you for that comment. So
I'm reading the last few chats, and you know, I think that yes, it can be very frustrating to see how things are in some places or with some caregivers, but you know, if now disrespect and abuse is recognized internationally by WHO, that really means something. If there's a charter now that you can, you know, use and show and train people regarding that, it's very useful too. And since quality of care now includes respect for women and respect during childbirth, these are all tools that can be used in order to help things change.
that's wonderful. And Sue, you sort of sum this up in the end. It is the women that will make the change happen in all countries where change has happened. Women have seized the responsibility and claimed their rights. We need to let them know they have these rights.
Yeah.
So we will be back in touch with all of you about the steps as we proceed to have them live and how you will be able to access. Actually, I think you can access, and I'm sorry that I don't have the answer for you, but we'll get it to you about how you access the archive, which will be on YouTube probably within the next week.
Thanks a lot, everyone. I'm really happy that you've been all there, and I was also happy to start that series. And I think it will be an incredible series.
Yes, and I just have to add these last few things. In Turkey, the Ministry of Health decided to have 4 hospitals mother-friendly, but there are a lot of talk about this. He said he would send us a report later on this, so that will be wonderful for everyone to receive that information. And good night from Lena. It's 1:30 there. We're glad you stuck around. So again, we appreciate you all joining us. You all have so much wonderful input yourselves. And as someone said earlier, this is a great foundation and a great place to start our series of webinars. So thank you, Lynn. Great job, great information. And we'll see you all again next time.
Okay, take care. Bye.